Welcome to the next episode of Lessons from the Lab. My name's Devon Rubin from Mayo Clinic in Jacksonville, Florida, and it's great to be with you again for another episode of this Lessons from the Lab. This is a Friday afternoon for me. It's been a great week. It's been a challenging week, and I always like to sit back at the end of the week and kind of think back about my week, whether it's in the EMG lab, whether it's in clinic. I think about some of the patients and some of the challenges that I've had and some of the successes that we've had in diagnosis and managing patients. And I will say that this has been quite a challenging week. I kind of, as I'm thinking about this week, I think if I named the week, I would call it a hedging week. I had quite a few patients where I kind of hedged on the report. Something we don't like to do. We like to know exactly what's going on. But as some of you might encounter in your practice, sometimes we encounter one nerve conduction abnormality or needle EMG findings, mild abnormalities in just one muscle, or something that doesn't quite fit in terms of a localization or doesn't quite make a whole lot of sense. And so our reports sometimes reflect that, and they should, as they should. They reflect the fact that we think we have an idea of what's going on, but we may not be entirely sure. I had a patient yesterday that was very, very challenging. It was a woman. I don't know what she actually has. She's still undergoing evaluation, but she had severe pain involving one arm that came on subacutely over the course of about a week, and then it progressed to the other arm, and she was left with very severe pain and numbness in both of her arms. When she was examined, this was a few months ago. In examining her, she had a fair amount of giveaway weakness. She was a bit tremulous, but when she gave good effort, her strength was completely normal. Her reflexes were completely normal. And she had her nerve conduction studies, and they were completely normal bilaterally. Her sensor responses were great. And I thought, as in many cases, that I would go in and perform the needle examination. It would be very normal. It would be a quick examination. And I examined her first dorsal interosseous. It was normal. Her pronator teres showed one little run of positive waves, which I kind of thought, well, who knows what that is. And I went to her biceps, and she had 3+ fibrillation potential with normal motor unit potentials. Her deltoid had the same thing. Her infraspinatus had the same thing. Her paraspinals had some fibrillations as well. They were profuse fibrillations, yet she was strong. She had reflexes, and her motor unit potentials were normal. So that was a head scratcher. She clearly has some acute or early neurogenic process, and maybe at one of the next lessons from the lab, I'll let you know what she has. She's still undergoing evaluation. But we encounter these cases in the lab, and sometimes they do challenge us. I had a great success also. They're not all, I don't always have problems with the patients. And this afternoon we had a patient with a brachial plexopathy, and our tech had difficulty obtaining a lateral antebrachial cutaneous conduction study. I was watching on the screen. I could tell she was struggling, so I went in to help her, and I put the stimulator right on the site. I increased the cathode and anode separation. I pushed a little less hard to reduce motor artifact, and boom, the response came right in, and it was beautiful. And she looked at me and she said, "You're just lucky." She didn't say that, but I told her, I said, I was just lucky. And we went through some technical tips that can help improve some of these difficult conductions. So a lot of things to think about this week. It's wonderful. It helps me improve my own knowledge and skills when I have these challenging cases. And I look forward to improving my knowledge during this Lessons from the Lab with a very special guest. And I'm going to present an interesting case, a common case, but pick his brain on how he would approach this patient and some tricks of the trade in evaluating the patient with a multitude of different techniques. So sit back and enjoy this next lesson from the lab. Well, welcome to the next episode of Lessons from the Lab. It's a pleasure to have another great guest, Dr. Mike Cartwright. Hi, Mike.
Hello, good to see you.
Good to see you. Dr. Cartwright is a professor of neurology at Wake Forest. He's an expert in electrodiagnosis and neuromuscular ultrasound. He's a good friend. He's a funny guy. He's a fun guy. And I'm looking forward to having some fun discussing and learning from you this afternoon on this great Friday afternoon. So thanks for taking the time to join me.
Sure, happy to do it. That's a lot to live up to, being fun and funny, and I'll do my best.
Yeah, well, that's all we're doing is we're trying to
Yeah,
do our best. So
yeah.
it hasn't been that long since I've seen you. I know we were at Ultra EMG a few weeks ago, I guess, in San Diego. That was a great meeting.
It was a great meeting. It's always a great meeting, and great location, fantastic instructors, great attendees. We had a good time.
There's only one problem with that conference, I think. It's that I can't go to your sessions and anyone else's sessions because we're doing demos and sessions ourselves. So the one downside is we can't listen to everyone
Yeah,
and
no, I
observe everyone.
agree. We've told this to Dr. Strakowski before, but he likes the format. I understand why he likes it. Maybe someday we'll get to attend each other's lectures.
Maybe it'll be like a wedding where, they have the party and then they have the after party. And we can just have an after party and just have us demonstrating the weirdest things, that we know. So just
Yeah,
with each other.
an after party
Yeah.
sounds great. Yeah.
People are probably listening going, boy, these guys are pretty geeky,
Yeah,
if that's their
exactly.
after party.
An electrodiagnostic ultrasound after party sounds,
I
yeah,
know.
fantastic.
Yeah, we won't have to charge too much for that one, right?
No, no.
Well, anyway, I even though I didn't have the opportunity to watch you there, I'm looking forward to learning a bit from you here. As you know, this goal of this for the people who are listening or watching is for us to discuss a case and to just kind of pick each other's brains. I'll pick your brain, kind of how you would be thinking about this case, how you might approach the patient, and just some general ideas about this patient. So um, I'm gonna present this case, and I'm gonna just share my screen. I just have a few slides of this case. So can you see that?
I
Oh,
can. Yep. 63-year-old woman with hand paresthesias,
yeah.
no
So basically,
cancer.
I can just read it and
Okay.
for the people who are listening. So this is a 63-year-old woman who presented for hand paresthesias. And she was pretty healthy. She had a history of ductal cancer in situ of the breast. She had hypothyroidism, but nothing else. Way back 30 years ago, when she was about 30, she did have carpal tunnel release. She had symptoms of right carpal tunnel syndrome. She had surgery and her symptoms went away. And apparently, she had a history of an ulnar neuropathy at that time and was put on a brace, and the symptoms resolved. And that was back 30 years ago. She's doing fine, no problems until just recently, really about 6 months ago, when she was 62 and she was typing more. She actually is a physician and she was typing more at work and had what she said was worsening carpal tunnel symptoms. And she had numbness and tingling in her palmar aspects of her thumb and index and middle finger. It was bilateral, but left worse than right. And she'd wake up shaking her hands. It's a pretty classic story. But her main concern, and this was really the reason for her referral to the EMG lab, was in the last month she had new numbness and tingling in the fourth and fifth digits bilaterally. So her ring and pinky finger. She might have said it was worse with neck flexion, but that was kind of a soft call. So she was referred more for evaluation of that than the carpal tunnel symptoms that she had in the past and had referred. And on her exam, her exam was pretty good. Her neurologic exam, she had decreased pinprick in her fourth and fifth digits bilaterally, but didn't have any weakness. Her reflexes were normal, and really nothing else on her examination. So, you ever see patients like this?
I see him all the time.
Yeah.
Yeah. I
So that,
did. Yep. I was in EMG on Wednesday, and I think I saw this patient there Wednesday.
yeah,
Yeah.
maybe she's making her rounds
It might be.
across the southeast. So I guess my first question to you, and I don't think there's a big surprise here of what might be going on, but maybe what would you be thinking the possible conditions or localizations are here?
Sure. Well, common things being common, we see a ton of median mononeuropathies in the lab, carpal tunnel syndrome. The things that are a little interesting about this case are, is she right-handed or left-handed? Do you know?
He is right-handed.
She's
Yes.
right-handed. Okay. Yeah. So she had a release on the right side 30 years ago, and that all fits. And then she now has worse symptoms on the left side than the right. So, her non-dominant hand has more symptoms than her dominant hand. A little confusing because she had surgery on the dominant hand 30 years ago. So to back up, I start by thinking, okay, it sounds like she's got some carpal tunnel syndrome, median mononeuropathy at the wrist. But then her new complaint really is the fourth and fifth digits. And that's probably what brought her to the lab, it sounds like, is not the carpal tunnel type symptoms, but the fourth and fifth digits. And so if you have one entrapment neuropathy, you are likely to have another entrapment neuropathy. So ulnar neuropathy at the elbow on both sides would be a consideration at this point. You can have ulnar entrapments or ulnar neuropathies at other locations. So it could be at the wrist. It could be, if you get really into the weeds on the elbow, you talk about the cubital tunnel versus the medial epicondyle or the supracondylar level. And so multiple different localizations. I think lots of times when we think about, mononeuropathies, we also include in our differential radiculopathies because they can look somewhat the same. She's got maybe some worsening symptoms with neck flexion. So you're thinking about, the carpal tunnel part, maybe a C6, or the ulnar part, maybe a C8 radiculopathy. A little strange to have a radiculopathy on both sides, but it's possible.
Yeah.
This is a electrodiagnostic conference, so we tend to focus on the peripheral nervous system, but it's always good to think about central causes. So maybe a higher cervical stenosis or even bilateral brain or brainstem issues would be possible. It depends on, what the rest of the exam looks like. But
Right.
yeah, that's where I would
So,
start my thought
yeah.
process with this patient.
Yeah. And I think that was kind of everyone's thinking that this sounds like carpal tunnel and ulnar neuropathy as the most likely and less likely some of the other things that you mentioned. And I do want to get into some of the weeds in a little bit, be a little more specific, but what I want to ask you is, so of course this patient is sent for evaluation, and I'm going to give you a very realistic scenario here. So the patient's sent for evaluation of this problem, but they want you to perform the evaluation on a deserted island, and the boat will only allow you to take one item that hooks up to the machine. You either can take a nerve conduction stimulator, you can take a concentric needle electrode, or you can take an ultrasound transducer. So that's your choices.
I
So
love that you
what are you
included the
gonna?
ultrasound.
This
Yeah,
is
I
like a
thought
joke.
I
What are
thought
you
you
gonna
might.
take?
Yeah, what
Yeah.
am I
So
going to take? I think that I'm probably going to not take the concentric needle. It's a good thought. Maybe you want to rule out a radic, and so you do want that needle to do that part of it. But oh boy, you put me on the spot. Oh gosh, we can do a lot with ultrasound these
well,
days,
I won't put you on the spot, but because obviously we're not gonna be on a deserted island with one
Sure.
item. But it gets to the question of it when you're approaching this patient in the lab for real. What do you do first? Do you do conductions? Do you do ultrasound? How would you approach this patient?
It's such a timely discussion. So I approached this patient first with nerve conduction studies. I would probably, be doing sensory and motor nerve conduction studies in this patient. The reason I say it's timely is one of my colleagues, Dr. Jim Karras, yesterday was talking to me about an ultrasound first approach. And we've talked about this for years, that maybe we could just, someone that comes in with classic carpal tunnel or classic ulnar mononeuropathy symptoms, maybe we just scan that area. If it's clearly abnormal with ultrasound, maybe we don't need to introduce anything painful, and we don't need to do any nerve conduction studies or EMG, and we have our diagnosis right there. And so we were actually chatting about this yesterday, and study design, and who would want to see that study, and would that study be a good idea, and should we investigate that further? We've talked about it, and we've actually investigated that with children, obviously trying to avoid pain as much as we can with our young patients in the EMG lab. And so we do use ultrasound first in kids. And
Mhm.
there's a few other scenarios, patients that might have suspected motor neuron disease and have already had a couple EMGs, we might start with ultrasound first there. We don't do it in this kind of case where we think about we're thinking about carpal tunnel syndrome or ulnar neuropathy at the elbow, but that doesn't mean that wouldn't be an approach in the future, which is why maybe on this deserted island I would bring the ultrasound transducer as my
Mhm.
one tool. So
But I guess the word that you said in that answer is what if there's clearly enlargement of the nerve, and I guess my question is what is clearly enlargement, right? If it's markedly enlarged, yeah, but what about, are you confident enough? Let's say you use I don't know what you use, a 10 millimeters squared cross-sectional area. Let's say if that's what you use and it's 12. Is that clearly abnormal? Are you confident enough that you would say, this is where the lesion is?
yeah, so it's a great question. I think you start with your pre-test probability, and so let's just assume we've got a high pre-test probability going into this, so based on the history and the exam. We use a cutoff of 13 millimeters squared for the median nerve at the wrist. Other labs might use 10, 11, or 12. It depends a little bit on your patient population. Um, you can make your diagnosis off of one single variable, the cross-sectional area of the median nerve at the wrist, but I think it helps to add other variables in there. And so we always will scan both into the palm and maybe even more importantly, up the forearm. And so we know that nerves are basically the same size throughout their course in a healthy individual. So starting at the wrist, going up to the axilla, you're not going to see a large change in cross-sectional area in a person without nerve disease. And so there's been several studies that have looked at how much of an enlargement is a significant enlargement. And usually most people will use 1.5 times. So if the cross-sectional area at the wrist is 1.5 times larger than the cross-sectional area at the forearm, that indicates focal enlargement at the wrist. There are other variables, so we tend to use a 3-point scale and grade echogenicity, mobility, vascularity. We sometimes will look for intruding muscle by flexing and extending the fingers. And then obviously looking for any other pathophysiologic finding. In this patient, they've had a carpal tunnel release, and so you might look for thickening of the transverse carpal ligament. You might look for scar around the nerve itself. So that's a pretty long answer for what you were asking, but
But
I would say,
what about the ulnar nerve though? Because the ulnar nerve to me seems more complicated. That you get more hypoechoic nerve at the interretrocondylar groove. Do you use the same criteria of a ratio, or are you just looking at absolute enlargement? That seems more complicated than the median nerve at the wrist to
I
me.
think in general, the ulnar is more complicated than the median at the wrist, right? Electrodiagnostically, clinically, treatment approach, all of that is more challenging for that ulnar nerve. But yeah, it's what you said. We do have reference values at all these sites, and so we would use an absolute cutoff, and then we would also use a 1.5 times increase. And as you alluded to, the ulnar, it's complicated because your enlargement could be at the entrance of the cubital tunnel. It could be at the medial epicondyle. It could be supracondylar. It could be different locations. The nerve does tend to be more hypoechoic even in healthy individuals because you're imaging it surrounded by bone, looking at the medial epicondyle and the olecranon. And so how much of a decrease in echogenicity is abnormal at the ulnar is probably less well defined than it is for the median at the wrist. We
Mhm.
also don't have great studies looking at vascularity for the ulnar at the elbow. So with those parameters that I was talking about for the median at the wrist may not hold as much water or as much weight as they do for the ulnar at the elbow. We look at mobility for the ulnar at the elbow. We look at subluxation across the medial epicondyle and dislocation. And I don't know if you want to get into that or not, but that can be complicated and confusing in and of itself too. So.
Yeah, no, I was going to ask you later on, but since we're talking about this already in terms of site of enlargement of at the ulnar nerve, I guess with the median nerve, if there's compression under the carpal transverse carpal ligament, you can have enlargement distal or proximal to that site of compression, right? On
Correct.
either side. So what I always wonder is if you have enlargement in the ulnar nerve at the retrocondylar groove, does that tell you where the process is? In other words, could you have compression at the cubital tunnel and have proximal enlargement in the groove? Or if it's enlarged in the groove, does it mean it's at the groove? And can we tell that? Do we know that?
It's a great question. I would I would guess that you might put a lot of weight on electrodiagnosis, which I would as well. And so there are studies that correlate nerve size with an inching technique to figure out where that drop in velocity or amplitude occurs across the elbow. And they correlate pretty well. And so I would argue that if you believe the electrodiagnosis, which I do, that and the ultrasound correlates with the electrodiagnosis, that where you see that enlargement is probably at or just adjacent to where the actual entrapment is. And so I would not expect the entrapment to be in the cubital tunnel and the enlargement to be retrocondylar.
Mm-hmm. Yeah. So in other words, if the enlargement is just at the cubital tunnel or just slightly proximal to that, that's likely where the lesion is. But if it's sort of above the groove or a little bit proximal to the groove, that's the lesion's at the groove. Is
Yeah,
that what you're saying? Yeah.
that's what I would say. I would say that maybe it's not definitively proven, but I think that, from my clinical experience, I would say that's correct.
Yeah. And I think and I think there is, I'm going to jump ahead just to one. You're probably familiar. I know you're familiar with all the literature because you're an expert in this. And but there was one paper that I found uh, looking at this. You're probably familiar with this. Looking at difference in the degree of enlargement and the site of enlargement or the enlargement between a 1 or 2 centimeter site at the cubital tunnel versus at the retrocondylar groove, and there was a big enlargement over just a 2 centimeter segment at the cubital tunnel, and much greater enlargement in size at the cubital tunnel rather than at the groove. Is that right? Did I say that right?
Say that last part again.
And the nerve is much larger here. Like it may be hard to see cross-sectional area of 60 millimeters, much larger in cubital tunnel entrapment than compression at the groove. But I don't know if that, the numbers here, this is one study, but the numbers
Yeah.
here say, you can get enlargement up into 30 and 40 millimeters squared when you have cubital tunnel versus 15, 16 millimeters squared at the retrocondylar groove. Do you
Yeah.
buy that, or do you?
Well, so this is done by Dr. Podner, who's fantastic. He's in
Yeah.
Slovenia and has done a ton of work on ulnar neuropathy, ultrasound, electrodiagnosis, intervention. And so I trust Dr. Podner's work for sure. Anecdotally, I'm not sure that I think that's a tough one. So I would say more commonly, we see the enlargement not at the cubital tunnel, but at the retrocondylar groove.
Mhm.
And so we have a lot more experience with enlargement there, that maybe it's a little bit more atypical to get the enlargement in the cubital tunnel. And maybe it is a little bit more dramatic when the enlargement occurs there. So yeah, that's.
But it sounds like that to you, the degree of enlargement doesn't help you as much as where the enlargement is.
Well,
Am I,
yeah.
in terms of localization
In
and
terms of
sites.
localization, it's about it's about where the enlargement occurs. And I don't know how much you're going to get into this, but we have talked for years about, well, maybe we should, there are different surgical approaches and different interventions for ulnar neuropathy, and maybe we should really try to tailor the surgical approach to where the enlargement is occurring. And maybe we should work really closely with our surgeons, and we do to some degree, but maybe we should do a study on this and figure out, can we be more directed in our surgical approach to ulnar neuropathy at the elbow by using ultrasound or inching or both to define where that entrapment occurs? And then the degree, the degree of enlargement does tend to correlate with severity. If you use electrodiagnosis as your gold standard for severity, there is a correlation to some degree, but it's not perfect.
Mhm. Yeah.
Especially if we go back to the wrist, the nerve enlarges as the entrapment becomes more severe, as there's more slowing, more demyelination. But then it kind of reaches a point and plateaus, and then we think at the far end here, where we start to lose axons, that maybe you even get, it doesn't enlarge any further and it starts to drop off a little bit. It's still large, if that makes sense, but you're no longer, it's not linear. And so
Right.
it's not continuing like that.
Yeah.
So,
Yeah.
yeah,
Okay. Um, you want to see the ultrasound that I did on this patient since we're talking about ultrasound?
absolutely.
And you said I'm probably more of an electrodiagnostic person. You're right. I mean, if I had to choose, I'd probably take the needle because I don't go anywhere without a concentric needle. Like when I go to deserted, to small islands, I just bring a needle with me anyway. So you never know when you're going to need a concentric needle. But I did do ultrasound in this patient. So
Yeah, good, good, good. Well, you could use that needle for more than just diagnostic testing too, if you needed to. So if you had to hunt small animals or something, you could use the needle.
that's right. You never know when it'll come in handy. You could use it
Right,
to like get a splinter out too. So
right, exactly.
So this is I'll just say this is a ultrasound that's on the machine. It's not a
Hmm.
standalone system.
Yep.
So I don't know if you use these, you probably have higher quality, but and I'm not the best ultrasonographer, so don't judge me on
We
this.
do
That's
both. We use ultrasounds as part of that are, incorporated into the electrodiagnostic device and standalone ultrasound devices. And I love that the manufacturers are adding ultrasound to their devices. I think that's awesome.
me too. It makes it so much easier. And so anyway, and I understand I'm showing you this. It's hard when you're not scanning. I get it. So it's going to be kind of hard, but I'll play it and then I can play it again slower if you want. I'll just play it through just a
Sure.
few seconds. So it's just repeating. I'll just kind of scan it through slowly.
Yeah.
Let's see. I'll go back. So here and yeah,
Yeah.
don't,
So this is so you're sometimes the video becomes a little choppy as it comes over Zoom and those kind of things. And so there's a little bit of a chop in there, but I got the idea. You're scanning the ulnar nerve. You are distal to the elbow right here. You're underneath the flexor carpi ulnaris. Is that correct?
yep, yep,
Yep. And so you can see the two heads. You can see the nerve if you want to point that out. Yep.
yeah,
And you can see, 3, 4 fascicles within the nerve. And then you see the two heads of the flexor carpi ulnaris muscle. And
yep.
so this is sort of and actually you can almost imagine the roof of the cubital tunnel over, superficial to the nerve itself. And so, right, that would be where the cubital tunnel is, the entrance to the cubital tunnel. And then you're scanning from distal to proximal.
Yep.
And, we would do a measurement. We like to get our first measurement or a distal measurement somewhere where there's not theoretically going to be entrapment. So it might be at the mid forearm. And then we also like to get one up in the mid arm. So we're at two areas that are far away from entrapment, but you would measure cross-sectional area. And then we would first do what you're doing and kind of scan over that area and try to determine where's the point of maximal enlargement. So I can make some measurements at that point. And so you're kind of down here in the cubital tunnel, maybe the nerve, it looks relatively normal in cross-sectional area. And then you start scanning proximally and it enlarges and you can tell that it starts, there's a little jump right there, but right in that area, yep, right around there is where it starts to enlarge and
Let me just
keep
get
going.
right to
Yep.
here. Yeah.
Yep. And so there I would say it's quite large. And you're
Here.
basically, that's the entire nerve right there. You've lost those fascicles, I would say, those 3 or 4 fascicles you could see at the beginning, you can't see anymore. The medial epicondyle is going to start popping out there. Yep. You've got the olecranon off to the other side. The ulnar nerve usually lies up adjacent to the medial epicondyle. And so that's your medial epicondyle
There's
right
the
there.
up
Yep.
condyle. Yeah.
Yep. So that's it right there. And you've
That's
got, if you go to right there, like freeze it, go back a little
right.
bit, right there. Yeah.
Yeah.
So you have, that's the nerve. It's very hypoechoic, almost anechoic. You have what we call posterior acoustic enhancement, so deep to the nerve. That's an artifact, and it's basically the ultrasound machine trying to figure out how quickly the sound waves and how strong the sound waves are coming back to the transducer. And so you sometimes with very anechoic structures, you can get this posterior acoustic enhancement. We think about that with cysts that you see with ganglion cysts, you see posterior acoustic enhancement. I didn't think this looked like a cyst, but I'll watch it as you keep going through this. It looked to me like it was probably just nerve enlargement.
Yeah.
Yeah, and
And
then
it
you're
starts to get smaller again there.
going further proximal, it starts to get smaller. Yep. And so you
Okay.
would measure it up in the mid-arm where you think there's no chance that it's being entrapped and get a cross-sectional area there. And you would measure it distal in the forearm, and then you'd try to figure out your point of maximal enlargement. This is great. So
Yeah.
this is your
Here's
forearm,
our
it looks like.
forearm.
Yep.
Yeah. There's the
Yep.
forearm.
So
These are
that's
the
probably
cysts.
the ulna off to my left side. And then, yep, right there.
Yeah.
And then the flexor digitorum profundus muscles are deep to the nerve itself. And that's probably the FCU is about to form superficial
Yeah.
to the nerve right there. So you get an area of 5 millimeters squared right there, which is normal, well within the normal limits. And
And then,
then this is where we start talking about the cubital tunnel and the two heads of the flexor carpi ulnaris. The nerve's a little bit larger here. It's 8.6, but not a huge difference. And then do you think this is your point of maximal enlargement? Is that how you
yeah, I
defined
think
it?
I
Yeah.
must have. Yeah. Because that's what
Yep.
I saved.
And so
Yeah.
now it's gone, it was 5 in the forearm and it's 21 in at this level right here, which is, I'm not sure if you're proximal or distal to the epicondyle. I think you're probably proximal or distal to the epicondyle here, but either way, it's right near the epicondyle.
Yeah.
And it's 4 times the size as it was. And then this is up in the arm, I assume. Yep.
Yeah. This might
And
not
this
be
is back
completely
down to,
accurate, but yeah. But,
yeah.
it's clearly smaller, right?
Yep. Yep.
Yeah.
So it increased by 4 or 5 times at the site of maximal enlargement.
So what do you think? So just a couple points about measurement. And, I think our techs and for us, it's harder to measure this, right? Especially here where the nerves, the elbow's bent and you're kind of trying to get the transducer around the elbow. Do you have any tips? Do you keep the arm, for example, in the same position you perform the conductions? Do you bring it out a little bit to make it easier, or any tips to get a perfect measurement there?
Sure. So we do the ultrasound in the same position that we do the nerve conduction studies. I do sometimes extend the elbow a little bit if I'm having trouble. What you want to see is you want to see the epineurium. You want to be able to see all boundaries of the nerve itself. And so extending a little bit sometimes helps bring out the image a little bit better. Rock the transducer, make sure your focus is at the level of where you're imaging. If your transducer allows you to change the frequency and you're very superficial, you might want to increase the frequency a little bit. That might help bring out the boundaries of the epineurium. Changing the gain can help. Changing the time gain compensation, which is the gain at different levels of the image, that can help.
Mhm.
So
What
all of those,
about
yeah.
what about like the problem of not being completely perpendicular to the nerve? I imagine that's a larger problem when you're curving around the elbow for
Yeah,
some people.
curving around the elbow is tough. Extra gel is always recommended when you curve around the elbow like that. If you are at a bit of an angle, so you're not perfectly perpendicular to the nerve, you could theoretically increase your measurement a little bit. If you think about the nerve being a tube like my pen here, and if you cut it perpendicular, you're going to get the smallest and most accurate cross-sectional area. Whereas if you cut at an angle, you're going to artificially increase that. But the amount that you artificially increase it is less than a millimeter squared. And so
Okay.
it's not, you couldn't cause something to be 20 millimeters square when it's really 5 or 6.
Yeah.
That's not possible. So
You'd have to have that transducer really, really angled so you're almost in long axis
right. You'd have
to
to
do
be
that.
doing
Yeah.
something wrong
Okay.
for sure. Yeah.
Okay.
So a little bit of, you tilt the transducer a little bit to try and get as perpendicular as possible. If you're not perfect, you're still going to get a very accurate measurement.
Yeah. How high do you scan when you're scanning? You said you go more proximal. Uh, I think we just went, I don't know, maybe 5 centimeters above the epicondyle here. In someone with a suspected ulnar neuropathy, if you find enlargement like here, would you go all the way up to the axilla, or do you kind of stop mid forearm or mid
It's a
upper
good,
arm?
yeah, no, it's a great question. I would most of the time, if I'm pretty convinced by the history, the exam, the electrodiagnosis that this is an ulnar neuropathy at the elbow, I'm going to do the scan that you just did, which is mid forearm to mid arm. I'm not going to go into the wrist. I'm not going to go all the way to the axilla.
Mhm.
Now, if you have a non-localizable ulnar neuropathy by electrodiagnostic criteria, then you might consider scanning all the way from the wrist up to the axilla. And I would say that different labs and different physicians approach this differently. So there are some people that scan everybody wrist to axilla, and there are others that are a little bit more focused, which is probably the approach I would take. But I don't think there's necessarily, if you went all the way to the wrist and all the way to the axilla, I don't think that's necessarily wrong. It's just,
Yeah.
it's going to take more time. But
So
yeah,
if you stop doing nerve conduction studies eventually, and just do ultrasound, then you might maybe you'll have to scan all the way up.
yeah, maybe so. Yeah, yeah.
So what do you think? We've jumped to the ultrasound, but we did do nerve conductions. What would you expect the nerve conduction studies to show at this with this?
I would expect that this person, I mean, it depends on what kind of studies you do, but I would think they're going to have slowing across the elbow. And then she, by exam and history, she had full strength. And so I'm not sure if you're going to see much, much amplitude loss or you might see some conduction block on this as well. And so you might see slowing, you might see conduction block. It's a pretty large and pretty significant enlargement. Um, but I would guess that if you did just a snap, just a sensory study at the wrist, that might be normal. And then a motor study is going to be slow, potentially with conduction block across that site.
Do you think you could have a completely normal ulnar motor conduction study and have this ultrasound?
You can always have everything. There,
Yeah.
there's never an absolute.
Right.
There is never an absolute. I think that would be pretty atypical.
Yeah, I do too.
Yeah.
So this is just to show you what was done. So for the ulnar, we did do the ulnar motor above and below elbow. I don't know. Do you do above and below elbow
Yep.
stimulation in
We would
this?
do
Yeah.
a study just like this. We read your book. We know you. We know. We listened to you. So
Yeah.
yeah, this is what we would
Well,
do.
this is the ANEM, practice parameter as well.
Sure.
But yeah, so I think I'm not going to ask you to interpret it, but for the people listening, it does show slowing across the elbow, certainly out of proportion to below elbow to wrist site. And it does show a bit of a conduction block. It's a 19% drop between the elbow and wrist there. So you think would you call that a conduction block?
Um,
You think it's
Yeah,
meets?
it's not 50% drop, but I think if you feel comfortable with your technological expertise, you probably should get the same amplitude across the elbow, below the elbow and above the elbow. So yeah, I would wonder if there is a bit of a
Yeah.
block there.
Would you do a short segment stimulation here? Do you do that?
No, I don't do that very often. I have colleagues that do it and like it, and I think there's nothing, I think it's a pretty cool technique, and I think that maybe in some ways I replace that with ultrasound, and
Mhm.
so I do a study like you have here, and then I do scanning with ultrasound to help one confirm the findings of the electrodiagnosis, and two maybe further localize. Whereas somebody else might use inching, I might use ultrasound.
Yeah, we do it, and
Okay.
this in this situation, the inching actually was a bit more confusing. And for this is stimulating across the elbow, distal to proximal, so from below elbow site to above elbow site. And for us, there actually is a bit of a drop in amplitude. So the epicondyle distance here is 234 millimeters. So the drop in amplitude was like 3 centimeters distal to the medial
Yeah.
epicondyle. Now, this patient might have also had a crossover because she had it on the other side. So that wasn't actually checked, and that could potentially affect that. So
I see.
it was actually more confusing to us because you'd say, that's an unusual site for there to be an ulnar neuropathy, very, very distal, but there's enlargement here. And then what do we trust? And
Right.
here I would
Right.
trust the ultrasound more.
Right.
So
Yeah, I usually, I'll take that piece of paper and line it up on these waveforms to look for a site of slowing. Does that make sense? Put a
yeah,
ruler across there to look for that. And then you're right, that waveform changes from the top stimulus to the second stimulus. It seems to lose a little bit of amplitude there. And
yeah,
so,
but the latency, this is hard to see because, and this is a still picture, I can't superimpose it, but the criteria that we use for short segment stimulation, abnormal latency shift is zero point 0.8 milliseconds over a 2 centimeter segment. So
uh-huh.
between site 3 and 4, which is at the medial epicondyle, is zero point 0.9. So that would be at, so, and you can kind of see that if you took a piece of paper,
Hmm.
there's a little
Yep.
shift there.
And
So
you can
yeah,
maybe even argue that fourth one, you might move the takeoff a little bit to the fourth, yeah, that one a little bit further, and maybe
yeah,
that would accentuate it a little bit more. But yeah,
yeah,
that was one of my things with inching that I always found, like I started playing with those markers and I could make it,
yeah.
just a little tweak and you just wonder, am I doing this or is this true, pathophysiology? And so yeah.
Yeah, and I think the other thing, just from technical standpoint, is you have to make sure that you're stimulating at equal distances at each site because, we say we're 2 centimeters, but if you're off, if you have to slide around and move and then you've slid and now you're only a centimeter and a half, that can have a significant effect on the latency that could look abnormal or it can make an abnormality look normal. So,
Are you going to talk at all about subluxation and measuring? And so you're, because when you start doing ultrasound, you see a lot of people that have subluxation of their ulnar nerve at the elbow, and that changes your imagined pathway of where the nerve is located. And so when you're doing your stimulation with an inching study, you may not be stimulating, the nerve may be taking a shortcut, if that makes sense.
yeah.
And so you may not be exactly stimulating the nerve. The measurements may not be accurate.
So do you think if anyone's doing inching, do you think we should, if we were going to do inching, should we ultrasound the nerve first to make sure we know exactly where it is?
Well, I think it all depends on what your point of doing inching is.
Yeah,
Like if your
okay.
surgeons, if someone's going to make a pretty big decision based off of this inching, then yeah, it might be good to do the ultrasound first and make sure it's not a subluxed nerve. This becomes super helpful, I think, in post-surgical ulnar cases, where the patient comes in and they don't remember if they had a transposition or just a medial epicondylectomy, or they had just their cubital tunnel was clipped to open it up. They don't know if the nerve's in the right spot or not. And so in those post-operative cases where the ulnar neuropathy has not improved or improved and then worsened, it's super helpful to have the ultrasound to know where exactly is the nerve if we're going to do nerve conduction studies.
Yeah. Yeah. I agree. I mean, I think in an ideal world, I think in an ideal world, we'd have our techs scan the nerves before they stimulate so they can give fewer, less stimulus intensity. They're right over the nerve. It's easier, but it's time consuming too.
It
So
is.
we
Yep.
don't do that. So
Yep.
anyway, so it showed that her ulnar sensory was low and slow. So it all did fit with an ulnar neuropathy. And then her median studies actually looked pretty good. So so from an electrophysiologic standpoint, she did not have median neuropathy at the wrist.
Yeah.
I did scan her median nerve too. You want to grade my median nerve scanning real quick?
Absolutely. Yeah.
So I'm
Did you
just
only study the left side? Is that correct?
on this side, we did some conductions on the right side,
Okay.
and her ulnar conduction was actually normal, I think, if I remember. Let me just show
Okay.
you. No, she had a slight shift in latency on her right ulnar inching.
Okay.
Here's her ulnar motor conduction. She had a little bit of a conduction block, and then she had a slight block and some shift there.
Okay.
So I don't think on this one I scanned the other side, the other ulnar, but yeah, I don't think we did. You would do both, right? If she had symptoms on both, you'd do both sides. Yeah.
I would. Yeah. Yeah.
Yeah.
And so this is the median at the forearm and the wrist. Is that what you have here?
Yes, this is wrist and then this is mid forearm.
Yeah.
There.
So the mid forearm, I can't read that number, but
So
it's oh, there it is.
7.4 and
7.4.
11.8.
Yeah.
And the ratio is 1.59.
Yeah, so it is a little bit. So the 11.8 would be below our absolute criteria for a median mononeuropathy at the wrist, but the 1.59 would be above our 1.5 ratio. I like to put all of this information together. And so if you told me that there were nerve conduction studies and you did sensory studies and a motor study and maybe even you did a mixed study or a combined sensory index or whatever you wanted to do to look really carefully and it was normal, I would probably not get too excited about the only thing being abnormal being that ratio.
Yeah. I think
And
that's a really, oh, go ahead. Go ahead.
I was gonna say, I'm saying, sorry. You could argue that on your measurement of your forearm right here, that maybe there's part of the nerve off to my left side of the screen. That little bright area, could that be epineurium as well?
Mhm.
If you collected that, maybe it would be below a 1.5. And so yeah,
Yeah. And I think that's such an important point that it would be very easy to look for some abnormality. Yes, this is a little bit abnormal ratio and give them a diagnosis. And I always feel the last thing I want to do is give a false positive diagnosis based on a borderline abnormality. I had this whole week. I think it was, I call it a hedging week because we had so many studies that they're sent for neuropathy and they have one value on a nerve conduction that's a little bit abnormal and everything else is normal. And to me, I'm not going to make that diagnosis when I'm not, clinically, I'm not quite sure. And it's just one borderline abnormality. I think it's better for us to underdiagnose rather than have someone go and have some unnecessary treatment. I don't know. It's the same for ultrasound, I imagine, and nerve conductions and needle exam too.
I think that's all true. I think that different labs do this differently. And so some labs, I think, see themselves as just really reading the numbers and the data and not necessarily incorporating the history and the exam, which I think is fine. I mean, I think that's if that's the way your lab practices, I think that's a totally standard way to do things. And then other times, some labs will, especially if it's like your own patient, you might interpret things with a different pretest probability and a different, their history and their exam, and much more than just a brief history and exam. And so I think you're right. You don't want to overcall things is certainly a great rule of thumb to go by.
But I would argue, and we could have a whole session on this, but I would argue that you can't do a study without a history and exam. I remember once years ago, someone said to me, I don't want to know the history and exam because I'm biased. I want to go in and do the study and not be biased to how I'm interpreting. And I get it, but I said, well, you kind of want to be biased. You want to have like you said, a pretest probability. What do you think this is? And does the study support it or not? And so, I think it would be unusual not to really have a good exam and history when you're trying to interpret this data.
I
Otherwise
Yeah,
we're just a machine. We're just a robot that's spitting out the numbers in this automated EMG study. And so,
I agree. Although I do think there are people that do it that way, and I get the idea of not being biased. Sometimes we talk with our pathologists, our muscle pathologists, our nerve pathologists, and we kind of want them to just one of my colleagues says, just read the meat. Just give us the information. Don't ask us about their history or about if they've been on steroids or not. Just tell us what it shows. And and so I do get that, but if we're going to teach electrodiagnosis and ultrasound as being extensions of the exam, then you have to have the exam. And so I'm with you.
yeah.
I agree.
So
Yeah.
if I showed you this ultrasound and you had no information about this patient, nothing
Yeah.
at all, said this is the patient's ultrasound, I'll give you an age. How would you interpret it?
If I was looking at these two images right
Yeah,
here,
yeah. These
I would
two, which you,
say, yep, yep.
yeah,
I would say,
you would hedge.
I would hedge. Yeah, I would say that
Yeah.
there's a possibility this person has a median mononeuropathy at the wrist, based on the enlargement of the wrist compared to the forearm.
And
But
then
it's a
you would
very,
say clinical correlation is advised, meaning you need a history and examination, right?
yeah, yeah.
Yeah.
So I don't know, there's all these arguments about using that phrase. I think Dr. Strakowski has always said that we don't put that phrase in there because we always do the history,
Yeah,
we know what's going on. And so, yes,
right.
you're right. It would be
Yeah,
hard to interpret without any background information.
right. Especially when, if you took the ulnar, I think if you took the ulnar ultrasound, you have clear, unequivocal enlargement. That patient clearly has pathology there. Now, they may not have symptoms, and that's where it sometimes becomes difficult too, that we find things that the patient is asymptomatic. We find, I'm sure you do, carpal median neuropathy at the wrist, and patients have no symptoms all the time.
Right.
So, yeah. So this is all important.
Yep.
So the last question here, actually two more questions quickly. So you're going back to the ulnar nerve ultrasound and the debate or the discussion about um, does ultrasound add information? Should you only do ultrasound? Should you do nerve conduction studies with ultrasound? Is that just your opinion, or is there is that others' opinion too? Whether you add ultrasound to assessment of ulnar neuropathy.
It's definitely others' opinions as well. I'm not on this island by myself. So it is this idea that it's this great opportunity to combine electrical information with imaging, anatomic information. And so I see a great consensus paper that has just popped up on the screen with Dr. Pelosi as the lead author. And there are other consensus papers as well that would argue for using ultrasound in addition to electrodiagnosis for ulnar neuropathy and for other entrapment neuropathy or other focal mononeuropathies. Yeah.
Yeah. And I think I'm showing this because it is a great paper and you were, I'm sure, heavily involved in this. And it's a nice summary basically saying what you've said all throughout this talk is, that both complement each other. And it is important to do nerve conduction studies. If at this point you're doing electrodiagnostic testing and all the things you talked about, ultrasound and measuring the nerve and assessing mobility and the whole length of the nerve, I think those are really important key points for someone who's learning this or doing this as part of their practice. So
yeah, this one's an expert consensus. So this was one of those Delphi multiple rounds of would you do this, would you do that, which was great. It's a great way to come to consensus. Steve Shook has a guideline, and so that's more of an evidence-based ultrasound imaging of the ulnar nerve guideline that suggests that there's enough published evidence that it should be used as a diagnostic technique for that situation as well.
So the last question, I'm going to just stop sharing this. So in this patient, and I don't have an answer for this question, but this patient, when she was 30, had carpal tunnel and presumably an ulnar neuropathy, and then now has ulnar neuropathy, probably bilaterally, maybe a little bit of carpal tunnel. Clinically, when you're seeing a patient like this, um, are there certain conditions that you would evaluate? I mean, this is a little unusual from an early age, and then now she has multiple compression neuropathies. Do you do anything in the clinic in evaluating them?
Yeah, I mean, I was taking little notes as you were presenting this case, and I put HNPP as one of my things I was writing down. And so hereditary neuropathy with a predisposition to pressure palsies. So basically, people that are more prone to get entrapments at any site. And so this person maybe has at least 3 entrapments that we know of, right? So bilateral ulnar based on electrodiagnosis and ultrasound, and then probably had carpal tunnel 30 years ago and maybe has it on the other side as well. So 3 or 4 known entrapment neuropathies. And HNPP certainly increases your risk of entrapments. And so you in clinic might ask about a family history of carpal tunnel or ulnar neuropathy. You might ask if they've had other things that sounded like an entrapment. Did they have a wrist drop? Did they have a foot drop at any point in their life? And then you'd have to decide if you want to do genetic testing to look for a PMP22 deletion. A duplication will give you CMT1A and a deletion will give you HMPP. And so the way I remember those two, the deletion versus the duplication, because I always used to get these mixed up in my head, is that people with CMT1A have huge nerves on ultrasound. And so I think about a duplication and doubling of the nerves. So that's when you get CMT1A. And then With HNPP and ultrasound, you get enlargement at the entrapment sites, but you don't get this diffuse massive enlargement. You might get
Wow.
some distal enlargement, but so to me, that's how I think about the genetics of it as
And you
well. So,
and you read my mind because that was the question I was going to ask. Because on nerve conduction studies with HNPP, there usually is an underlying mild neuropathy on top of the compression neuropathies. So
right.
that's often a clue. I think I can't remember in her if we did some other like lower extremity conductions, but if that was a concern, we would have done that.
Yeah.
But yeah, so on ultrasound, it does that wouldn't really help you a whole
It's going
lot.
to show those enlargements for sure. And maybe a silent enlargement somewhere, like if they weren't clinically having a median mononeuropathy or something like that, you might find it. But looking at a bunch of sites with ultrasound is probably not going to be a good use of your time in this case. If you really thought that she had HMPP, you go to genetic testing and maybe electrodiagnostically look for a underlying neuropathy.
So there's still a role to put on the boat a nerve conduction stimulator in addition to the ultrasound transducer when you're doing your studies on a deserted island, right?
I agree. And you want that needle too. So it sounds like we need all
Yeah,
three.
you
Yeah,
got you just can't do them on a deserted island, I guess. That's the
right,
take home point. So,
right.
well, thank you so much. This has been terrific, great practical information. I think the only thing better would have been to have you physically here and us scanning each other and discussing it in front of a machine. But we'll do that again somewhere else, either at Ultra EMG or ANEM or somewhere else. And I greatly appreciate you taking your Friday afternoon and teaching me and teaching everyone who's going to be watching or listening to this.
Absolutely. I appreciate you asking and had a great time doing it.
All right. Have a wonderful weekend.
All right, you too.
Bye bye. Thank you for tuning into this episode of Lessons from the Lab. It was really wonderful speaking with Dr. Cartwright. He is such an expert in neuromuscular ultrasound and EMG, and the points that he makes are quite valuable. They will certainly help me and improve my skills and improve my thought process in evaluating patients with neuromuscular disorders, both with nerve conduction studies in EMG and neuromuscular ultrasound. It's wonderful to hear the tips that he uses in interpreting and these ultrasounds and scanning patients. And hopefully, everyone who's listening or watching will have some opportunity to learn from him in person at one of the meetings or the workshops because he really is quite uh, uh, amazing at how he teaches this skill. Uh, I guess one take home point here is that it's probably better to perform EMG and neuromuscular ultrasound in our own labs rather than on a deserted island. And it's nice to have different techniques as part of our armamentarium to evaluate patients. And there's a role for needle EMG, there's a role for nerve conduction studies, and there's a role for neuromuscular ultrasound. So enjoy and think about this, and I look forward to seeing you next time. Bye bye.